Our presentation today will be a little bit of a different taste. It will be a case scenario of a patient I followed for 2+ years. And we will talk about different topics throughout the presentation. This lovely boy was a 5-year-old when he presented with anemia and reticulocytopenia. His past medical history was pertinent for many things, including immune thrombocytopenia or ITP when he was 2 years of age, alopecia areata, recurrent aphthous ulcers, recurrent fevers were mainly URIs and ear infections, but no serious infections, eczema and urticarias with multiple skin rashes, and low IgM and IgA. His exam was normal except for a mild hepatomegaly and splenomegaly, and he had no congenital anomalies. Initial workup included a CBC that showed a normal white count, normal platelets, normal ANC and ALC, but his hemoglobin was 6.1 and reticulocytes were low at 0.2%. Other tests, including the MCV and hemoglobin F, were both normal to look for inherited bone marrow failure syndromes. His viral workup, including EBV, CMV, parvo, and mycoplasma, were all negative and non-revealing. Because of the recurrent history of fevers and URIs, an immunodeficiency workup was done, and it showed elevated CD4 positive T cells. They were slightly elevated, decreased B cells, and decreased NK cells. And as we said, his IgM and IgA were both low. As we all know, bone marrow biopsy will be done next to reach a diagnosis, and his bone marrow was normocellular, but there was absence of erythroid precursors with increased T lymphocytes. And based on this finding, his diagnosis was pure red cell aplasia. You can see in the above, in the top figure, squashed erythrocytes, and you can see the hemoglobin staining with glycophorin A in the bottom one. So what's next? For pure red cell aplasia, usually you leave some time to observe, because most common reason is a transient erythroblastopenia of childhood or TEC. And usually it's recommended to observe for about 1 to 2 months. And unfortunately, he continued to be transfusion dependent throughout this time. Next step, and it's not done every place, but an IVIG attempt can be done, especially that for this patient, he had ITP before, if you remember, when he was 2 years, so he was dependent on IVIG. So another dose or two would not harm. Before going to the first line or gold standard, which is high-dose prednisone. And you usually start with a high dose, 2 milligram per kilogram per day, for 2 to 4 weeks until you see a response, and then you start tapering. Most of the children will respond to steroids, but unfortunately this patient did not. Next step, and this comes from literature from Japan mainly, second line will be an immunosuppressant, and this is cyclosporine A. Usually half of the patients that does not respond will respond to cyclosporine. Luckily, he became transfusion independent after starting cyclosporine and tapering prednisone. Story here is typical, nothing interesting. But 6 months later, this same patient relapsed again with the same presentation. He presented with a hemoglobin of 6.1 and a reticulocytes of 0.4%. In addition to that, his ANC, or acute neutrophilic count, was also low, was severely low at 400. But his platelets were normal, and his ITB already resolved after he presented with pure red cell aplasia. A repeat bone marrow showed similar findings in addition to decreased granulopoiesis that will explain his neutropenia. His myelodysplastic syndrome panel was negative, as well as parvovirus DNA PCR from the bone marrow. And this test is the gold standard for a chronic parvovirus infection, especially in immunodeficient patients. But despite this, this was negative. Again, we know he does not respond to steroids. He relapsed on cyclosporine. So another immunosuppressive agents should be started, and the two more common ones are MMF or Cellcept and sirolimus. But he responded to neither of those, and he continued to be transfusion dependent. Just to summarize his case, if you look at the top here, you can see we gave him prednisone and IVIG. This is when he presented with a puret cell aplasia initially, and he was transfusion independent. You can see he received about 10 or 9 transfusions until cyclosporin worked, and he became in remission. But then he relapsed again 6 months later, and neither MMF or sirolimus worked, and he continued to be transfusion dependent. If you look at his ANC, it used to go low occasionally with IVIG through his ITP treatment, but then mostly it was normal until he relapsed and he was severely neutropenic. This is when he had ITP. Once puret cell aplasia was diagnosed, his ITP resolved and his platelets continued to be normal. Because this case was not typical and this puret cell aplasia relapsed, and this rarely happens in children, with all the other manifestations he had, we looked for other reasons. One of those, autoimmune lymphoproliferative syndrome, Fanconi, and Diamond-Blackfan anemia. Although he did not have any of the manifestations to suggest, but just because we did not have a diagnosis, we wanted to look at the genetic panel for those, and those came back negative. Next step will depend on the physician. Some physicians and the resources that are available. Some physicians will continue to send panels. Some others will just go broad and send whole exome sequencing. And this is a genetic technique, looks for a protein coding genes. It's not available everywhere, but I was in the States when I had this patient, so I was fortunate to have this test easily available. At the same time, while we're waiting for the results of the whole exome sequencing, it takes about a couple of months. And after reviewing the literature, looking for a puret cell aplasia, there was the American Society of Hematology conference, and there was this abstract from Texas Children's, adenosine deaminase 2 deficiency as a cause of puret cell aplasia mimicking Diamond-Blackfan anemia. And when you look at the abstract and the patient manifestations, it fits about 80% of the patient I had. Not surprisingly, this patient mutation came back positive for this CSER1, which was the same mutation that Texas Children's discovered. And he was compound heterozygote. He had an allele from his mother and another from his father, who were both normal, by the way. Another nice thing about this disease, what's called DADA2, or deficiency of adenosine deaminase 2, is that there is an enzyme level that you can send, similar to SCID patients with adenosine deaminase 1. This is the other subtype, adenosine deaminase 2, and there was one lab that can do that. And when we send it to confirm, the level of the enzyme was low at 0.6. So let's just talk a couple minutes about deficiency of adenosine deaminase 2. This disease was discovered recently in 2014, just 4 years ago, by 2 separate groups independently. And they utilized whole exome sequencing to discover the disease. It's recessively inherited loss of function mutation of CSER1 gene, and it encodes for the ADA2, so it causes DADA2. Just on the cellular level, what happens, as we said, ADA1 deficiency is what causes SCID that we know. ADA2 usually works intracellularly, not extracellularly, in contrast to ADA1, and it acts mainly on monocytes. So its function is to have a balance between M1 macrophages and M2 macrophages. M1 macrophages are the inflammatory or hyperinflammatory macrophages that are responsible for immune stimulation and tissue injury, while M2 is responsible for immune suppression and tissue repair. So what ADA2 deficiency does is it polarizes macrophage differentiation into M1. So it causes more autoinflammation, hyperinflammation, and tissue injury. When it was first described in 2014, it was a triad of autoinflammation, mild immunodeficiency, and vasculopathy, mainly strokes in young children, and polyarthritis nodosa and vasculitis. It can happen at infancy, it can happen in adults as well. And severity depends, it can be limited, cutaneous, or multisystemic. When a genotype or a mutation is discovered, the next step is to define the phenotype to help the physicians to diagnose it. So it was divided nicely into 4 phenotypes, and it's still expanding every year. Stroke phenotype, this was what NIH discovered first, and it was about 24 patients that presented with stroke. All are less than 5 years of age, almost all. And it's usually lacunar and ischemic. Rarely it becomes hemorrhagic strokes. The polyarthritis nodosa phenotype can be localized on the skin and can be systemic, mainly in the GI and kidneys or the skin. The B-cell phenotype or the immunologic phenotype, as we saw in our patient, decreased number of B cells. Usually it's mildly low, and usually those are from the switched memory cells. And decreased function of T helper cells. Sometimes the NK cells will be decreased as well. And this is the new phenotype that this abstract I talked about was the first patient who had this puret cell aplasia with this manifestation, and our patient was the second. And it's usually an atypical Diamond-Blackfan anemia. When you send the genetic testing, it will be negative. So what happened to the patient? As we said, he relapsed. Nothing worked. None of the immunosuppressive agents helped him. But in addition, he was neutropenic this time. And he became severely neutropenic or profoundly neutropenic with an ANC of less than 100 for about 2 months. And this is per se is an indication to go for transplant. And that was the main reason we transplanted this patient. Looking at the literature, there was only 1 patient who was transplanted for this condition at that time. But there was about 3 patients who were transplanted retrospect, because as we said, the disease was discovered later. So we had to do a hematopoietic cell transplantation from a matched unrelated donor. His transplant course was smooth. Interestingly, he developed an ITP-like picture with an antibodies to glycoprotein 2B3A. And this ITP was so resistant to treatment. His platelets were less than 5,000 for about couple of months. And he was a high risk of bleeding. So we tried everything, including IVIG, HLA-matched platelets, rituximab, as well as sirolimus, but nothing worked. And the only thing that worked eventually was romiplostim, which we will talk about this agent in a couple of hours. It's a thrombopietin receptor agonist. He received it weekly for about 10 weeks or so, and it was able to correct his platelet count. He did not need any splenectomy. He had alopecia areata, like we said, and this bald area pre-transplant demonstrated some hair growth after. So transplant did not only correct his hematopoietic manifestation, but also some of the systemic features, interestingly. And this was the alopecia that he had for years. And you can see it's the first area that had hair growth post-transplant. One nice thing when you do transplant for patients is if you have an easy test to follow, other than chimerisms that we know. For thalassemia, for example, or sickle cell, you can do hemoglobin electrophoresis. So this disease, we had the benefit of having this ADA2 assay that we sent. So as we said, it was 0.6 before transplant. And when you followed it up at 1 month, 2 months, 3 months, and 6 months, you can see it became normal all through. You can follow also his chimerism, and this is all from his donor. And at the end, this is a common photo that you see on the internet for different issues and things. But in our topic, I think what it means is if you look narrow at the patient from one side, we'll never figure it out. But when you have a multidisciplinary team and you look from afar, then it becomes easier to figure it out. This patient is now, I think, 2 years from transplant, and there are more than 15 patients who were transplanted for this condition since then. That was published just last month. And thank you.